We are good to go, sir.
Okay. Is it okay? Good to go?
Yes, sir.
Yeah, good evening all. Myself, Dr. Kiran Varma, working as head of the emergency department, Yashoda Hospitals, Somajiguda. So I welcome you all on behalf of Yashoda Group of Hospitals for the series of webinars connected by emergency department, Yashoda Hospitals. So as you all aware that, so we come up with an interesting topic every week with, so where our experts throw a light on it and where they will share their thoughts about particular topic. So actually we have come up with an interesting topic for this week as well. So this is one of the most common cause of medical emergency, one of the most common cause of ED visits. So topic for today is GA, gastrointestinal bleed. So it might be upper GA bleed or lower GA bleed, varicose bleed, non-varicose bleed. So there are many controversies, updates regarding particular topic. So then to enlighten about this topic, to throw light on this particular topic, so we have Dr. M.K. Desai, who is a good friend of mine. So I feel very happy to see him here. In fact, it's my pleasure to invite him for this talk. So who completed, so just to be a few brief about Dr. Desai. He completed MBBS, then Diploma in Emergency, then Master in Emergency Medicine from Semi-Board, then FRCEM. Right now, then HST-EM, Thames Valley Deanery. Now he is working for Royal Berkshire Hospital, Oxford, UK. Thank you, Desai. Thank you so much. First, I would like to congratulate on completion of your FRCEM. So,
thanks a lot.
I feel very happy for it. So now I hand over the forum to Dr. Desai.
Look, thanks a lot for the introduction, sir. I am really happy, and thanks a lot for Yashoda Hospitals and Varma, sir, specifically, who has asked, like, can you please, we are doing this. I think you'll be interested. Like, definitely, sir. Let's do one common date and then go ahead. And yeah, so I'm really glad that I am taking part in this, and hopefully, if everything goes well, in the near future as well again, right? So without any delay, let's go ahead with gastrointestinal bleeds in the emergency department. As Dr. Verma has already told, this is the reason why we are talking about this. Is one of the common presentations, common emergency presentations to the ERs throughout the world, with whatever the cause might be. It can range from simple on and off bleed to a dramatic bleed, which makes you run through the blood bank, getting a lot of transfusions, everything. So it is one of those presentations where you have to be on your toes all the time and then make sure that you're not missing anything. Without further delay, let's directly jump to the first case. So this is a 44-year-old local politician who was brought in the middle of the night at 2 a.m. You've got yourself, the junior consultant on the shift, and a PG who is year 1. They are waiting with you, and one more PG or 2 who are just with you to help you. And this is the patient, as you must be, given the situation, there's a lot of crowd and everything. Medically, he has been feeling unwell since last 2 days with abdominal discomfort. He had an episode of syncope at home, following which had an episode of vomiting in the blood. As you can see, this is the amount of blood on the shirt that you can see. It reflects what exactly has happened in the home. Now, what would be your next steps? So immediately move the patient to monitored bed, start resuscitation, get large bore IV cannulae. bloods, including group and screen, and attached to the monitoring. And when we attach the monitor, these are the vitals. He's tachycardic, has got blood pressure, borderline blood pressure, maintaining saturations, tachypneic, sweaty, has clammy peripheries. All right, at this moment, he realized that, yes, this patient is really unwell and he is needing immediate resuscitation. Furthermore, a bit more about the history is that he is a chronic ethanolic, about 500 ml of spirits per day, had a recent binge alcohol episode in the last couple of days. He's got sunken eyes, having mild icterus, has got central obesity, muscle wasting in limbs. What are the things that first come to your mind? What are you thinking? Management-wise, what do you think needs to be done? Fluids? Are you going to start with blood directly? Is there any role of PPIs in this case? When you're thinking about all of these things, he had another episode of fresh hematemesis in the emergency department then and there. What next? So, to answer these questions, let's go a bit about what is upper GI bleed. So, textbook-wise, the definition is any bleeding, GI bleeding, which originates proximal to the ligament of Treves, that is in esophagus, stomach, and first couple of parts of the duodenum, is upper GI bleed. Clinical features. It can present with hematemesis, which is one of the common things. 1 in 2 patients have hematemesis. Bright red vomitus, which if there is bright red vomitus, you can tell that it is actively bleeding at the moment. Coffee ground vomitus. It is assumed to be blood. What happens is when you swallow the blood, because of the gastric pH, the secretions of the gastric which it breaks down the hemoglobin and then makes it look like coffee ground. It is not the color, but the ground. It is like when you put the decoction, coffee powder to the decoction, the last thing, the dust that is the ground, the last thing that is left in the filter, that is called coffee ground. So that is what it is. Melena is present in about 70% of the cases. So never to miss a PR examination. Hematochezia. This is hematochezia means that you are passing a large amount of blood from the upper GI, that there is fresh bleeding from the PR. And not to miss are the features of shock, like tachycardia, anxiety or confusion. If there is anxiety or confusion, that means that the brain is not perfusing enough. Tachypnea, cold, clammy skin, oliguria, hypotension, all of these are suggestive of a shock. Put some pictures to show what do you think, what it should be like. When you do a PR examination, and then you have to, after the gloves, consent, everything, do a PR examination, and then rub it on a white tissue. If you see that, it should be like probably the color of your hair, and then it is called as melena. Hematochezia, as you can see, bright red blood, which is directly in the toilet. And you can see the regarding the coffee ground vomiters, you can see that the ones, I don't know if I can point here. Yeah. So these ones, these specks, this is coffee ground. And coming to the causes, the common 3 or 4 causes are most commonly which make the patient come to the emergency department, which include peptic ulcer disease, Malravis stare, esophagitis, erosion, and most importantly, variceal. The reason I'm stressing a bit more on the varices is because when it comes to treatment, variceal treatment is a different league and non-variceal treatment is a different algorithm. You can broadly divide like that. What are the key points in history that we should be knowing about? The events prior to bleeding episode, like what happened? Were they eating? Were they did they had an episode of profuse vomiting or retching? And then did they lose consciousness? What happened before, during, and after the episode of the bleeding or vomiters? The severity, frequency, and quantity of bleeding in the episode. So the shirt that I showed you, it could be approximately anywhere between 50 to 100 ml to soak that amount of blood. So a lot of people, if possible, the common things that we use at home are probably a mug or a bucket, which can have some gradations, and then you can understand what exactly is, how much amount of the bleeding is there. Appearance and color of the bleed. So if it is bright red, suggestive of ongoing bleed. If it is a bit dark, probably, and coffee ground, probably it's been going on since a bit of time, but they have not vomited yet. Sometimes you can see clots as well. Any previous episodes of upper GI bleed which needed intervention, or previous H. pylori infection, particularly with the rise of having food in outside eateries. It is very common. It is extremely common to have H. pylori infection, particularly in our part of the world where it is the Swiggy, Zomato, the fast food culture is very common. And about the medications, are they on any aspirin? Do they take regular NSAIDs? The reason why we ask this is aspirin, NSAIDs, they can cause esophagitis, gastritis. And aspirin itself, the presence of aspirin or itself makes the bleeding more profuse, and the difficult to clot is also high. Anticoagulation as well. It is more common in Western world, where there is, you throw a stone in the crowd, at least 10 people will have anticoagulation. It is that sort of situation. Other significant past medical histories: known peptic ulcer disease, liver diseases, and other coronary artery disease. They might be on dual antiplatelets, which make it a bit more difficult for us to go ahead with the controlling the bleeding. Social history like smoking and ethanol consumption. Then, now, why do you collect all these factors? Why do you want to know about all these things on the history? That is for risk stratification. What suggests that it's going to be a poor outcome? Advanced age, multiple comorbidities, liver diseases, inpatient, outpatient having UGI bleed versus an inpatient having UGI bleed. The chances of the inpatient the chances of severity of disease being a bit high. The morbidity and mortality are higher in inpatients, particularly. Initial shock, ongoing bleeding, hematemesis, hematochezia, and elevated blood urea. All of these suggest that there is higher risk associated with this outcome. The reason why we want to know this is to involve ICU and advanced therapy early, and to have whether to take the immediate intervention to the management or delayed. For risk stratification, there are other tools like Rockall scoring system, which uses just three of main things like age, shock, and comorbidity. And then maximum score is 7 pre-endoscopic. And so to say a Rockall score of 3 before endoscopy means about 10% mortality rate. If it is 6, 1 in 2 patients are going to die. In our patient, he was less than 60, which is a good thing. He was hypotensive, and he had possibility of renal issues. Then that means that liver issues. His pre-endoscopic is higher side. Therefore, he would be having higher mortality rate. The other system, which is much more common in the UK at the moment, is Glasgow-Blatchford score, which takes into account a bit more and clinical presentation as well. The reason Glasgow-Blatchford is a bit more preferred is because it includes melena and syncope. So our patient had syncope, liver disease. The bloods were, even if the best would be about 13, that's fine. And the urea is probably on the higher side, and hypotension means that they are going to need an immediate scopy. The investigations we do, you do immediate blood gas levels, which can give you hemoglobin. It guides your blood transfusion. Not that, so the number on the hemoglobin, the number of hemoglobin on the blood gas in acute GI bleed might still be okay. So they might have vomited about 500 ml of frank blood, but still their baseline, if it is 13, it could be probably still around 11 or 12, which is not necessitating immediate blood transfusion. But combined with the clinical features of if the patient being clammy, cold, the stickers are coming off, the monitors are going, the cannula, the cannula tegaderm is coming off. If all of this means that there is something really bad happening, they might need blood immediately, blood products immediately. Urea and electrolytes, urea will be raised after say bleeding because of the blood, the way blood is processed in the gut, and then urea is released as a product of that. FBC to know what exactly is going on, the hemoglobin. You get a better picture about acute bleed or chronic bleed and anemia level and everything. Coagulation screen, particularly PTINR, liver functions, and cross match, blood group and cross match, definitely, yes. Portable chest X-ray, likely, because when particularly people are having back-to-back vomits, there is a small chance of having esophageal tears. As long as if it's just a mucosal tear like Malravis, that's fine. But if it is a big tear, then you might have to be considering about involving the surgeons as well. CT scans and other things to rule out Borheff's. The most common investigations that we tend to do are CTs or X-rays, but sometimes abdominal X-ray might need to be done when you're particularly asking. My personal opinion, abdominal X-ray is only useful for toxic megacolon just to limit the amount of radiation. But otherwise, I think everybody should get a CT in such acutely ill patients. Coming to the treatment aspect, we are going to talk about mainly non-variceal bleeds versus variceal bleeds. PPIs. PPIs are shown to reduce bleeding by increasing the pH of normal acid gastric pH, therefore increase clot stability. Post-endoscopy also reduce the rebleeding rate and need for escalation to surgery. Sometimes in the UK, NICE says not to give, the NICE guidance says not to give PPIs before the endoscopy, as for it, because it makes it difficult for the endoscopist to find the bleeder if the clot and everything has been done. But I would give rather than not give. Antifibrinolytic therapy, recently published heart rate trial about 4 years ago. It showed that Trenexa does not reduce death from GI bleeding and should not be used as a part of uniform approach to treat GI bleeding. In fact, the arm which had Trenexa had higher incidence of pulmonary embolism and venous thromboembolism. Basically, that is the reason why halt it. This proved that Trenexa works any better. It's better not to give. Somatostatins, they are not recommended routinely unless there's a huge delay to endoscopy. Let's say you are in a rural setup, which is like 6 hours or 5-hour drive. The earliest you can transfer is probably about 6 to 12 hours later, and they just had a big bout of vomiters, and then they are trying to stabilize it. That is when somatostatins can be given in non-variceal bleeds. But otherwise, in the recent times, we have got gastroenterologists in almost everywhere. Every district headquarter usually has a couple of, if not 10 or more, at least 2 to 5 definitely available. And then metros always have on-call gastrointestinal gastroenterologists. So it should not be a big issue. For variceal bleeds, things are a bit different. You use vasopressins, which is the drug of choice is terlipressin, which is safe and effective. It acts by inducing vasoconstriction, therefore reducing the portal venous pressure, and it reduces the blood loss from actively bleeding varices, and is shown to reduce the risk of mortality. This is something that I would start in the emergency department, particularly if there is a strong stigmata suggesting a liver disease or a variceal disease. Antibiotics, all the patients with suspected, not just confirmed, suspected upper GI bleed with variceal stigmata should get antibiotics. Most commonly ceftriaxone. If they are allergic or anything, possibly then ciprofloxacin. So about 20% of cirrhotic patients will develop a bacterial infection within 48 hours. About vitamin K in variceal bleeds, there is a Cochrane review that concluded that there is no evidence of efficacy of the for administration of vitamin K in patients with liver disease who have acute GI bleed. Acutely, it's not going to change much. Vitamin K, if you give vitamin K, what is going to happen is it increases the 2, 7, 9, 10 factors, and that is going to take at least 48 hours. So within 48 hours, nothing much is going to change. In the ED, not much of a role, but eventually, yeah, probably if they are definitely having, what actually helps is PCC. Other important things, these are the medical management. Now, non-pharmacological therapy, gold standard management is endoscopy. If the patient is too sick, then probably we do our resuscitation, admit to ICU and bedside endoscopy sort of situation. If not, you've given enough therapy, they have not showed any further worsening, then admit to higher monitoring units or HDUs, ICUs, and then keep a close eye. And then within 24 hours, they should have endoscopy. When coupled with injection or thermal therapy for a bleeding peptic ulcer or banding for varices, it reduces the mortality significantly. High risk bleeds, like the ones we have discussed based on Glasgow Blatchford or Rockall, immediate urgent endoscopy needs to be done. The other things that we can do are, if there is, the other things, further escalation could be open surgery or angiography to exactly point out at the bleeder, and then embolization, most commonly done by the interventional radiologist, or a TIPS in advanced cases of variceal bleeding. Now, let's talk a bit about balloon tamponade devices. How frequently do we use it? I've seen the last things taken Blakemore being inserted when I was in medical college in, probably more than a decade, not a decade, even more. I'm old now. Yeah, even more. That was the last time I've used and seen one use because of the increased availability of gastroenterologists in the recent times. So basically, this is the most common thing that we use, Sengstech and Blakemore. Single thing, in a conscious, awake patient, nasal approach, if not intubated patient, oral approach, you just pass a tube down to the stomach, inflate the gastric balloon. So for Sengstech is 250, for Minnesota is 500 mils of air, and then you pull. When you feel the tug, stop, and then see if it is reducing. So what you can do is, with this regards, Minnesota is better because you have got esophageal suction and gastric suction ports as well. If it is still bleeding after you have inflated and then put a tug, it means if you are getting blood from the gastric port, then the bleeder is a bit further down. Or if the bleeder is coming from the esophageal, then it is possible that it's probably from the esophagitis / varices. At that point, you inflate the esophageal balloon as well, and then hold. This is a temporary measure, gives you about 6 hours, the best, because after that, it's going to cause tissue necrosis. It's going to be much difficult to deal in the long term. Tissue necrosis, strictures, all of these things can happen. And the problem is with this is a slide to just, everything is contraindications and complications. Yeah, it controls bleeding well, but there is a higher chance of rebleeding as soon as you deflate. You have to deflate because to prevent tissue necrosis, just like ED tube. So you need to check with manometer regularly to see how much it is, what is the pressure, because sometimes the pressure just leaks and then it's a bit of a hassle. But if that is what it is there, if you cannot have a, let's say you are working in some rural setup in one of the secondary centers, sort of a situation where you have to transfer, and then this is the time saving maneuver, that's it. The problem associated with this is the lack of availability and then lack of usage in the recent past means that not everybody is acquainted to how to use it. The chance of it being placed erroneously in a wrong place is higher. And then if it is not very well secured, then still vomit can happen. They can still aspirate, and then can sometimes migration of the tube is also common, just like ET tube displacement. This tube can also get displaced. So yeah, this is the basically enough. Taking a bit of break from that, coming to management again. Hemorrhage. You go basically with the guidance of as per the ATLS to check what exactly is the situation, and then see if there is any based on the shock. Basically, if it is class 3 shock, I'm going to start with blood to begin with. If it is severe shock, I have massive transfusion protocol and everything. On this note, let's go and talk about blood transfusion. What are you aiming at? What is are you going to go 1:1:1, 2:1:1, 4:2:2? What exactly are you going to, if it is a major transfusion? So let's talk a bit about that. The RBCs, packed RBCs, PRBCs is what we are going to use. Aim is to keep hemoglobin more than 7, but in anybody with cardiac, long-term diseases and everything, 9. 9 is the aim. And then platelets. Most of the conditions, liver disease patients chronically have thrombocytopenia. It is not uncommon. They tolerate, so 100 plus, it's as good as being okay. Platelet less than 50,000 is when I'd be concerned, and then I'd start the platelet transfusion. Platelet less than 20, you go start with SDP. If even less than 50, ongoing bleeding, SDP is better than RDP on any given day. FFPs. So this depends if they have got a long-term decompensated chronic liver disease, which is affecting the factors present, the clotting factors as well. They can have INR on the higher side. At that point, you'll have to transfuse plasma as well. And cryoprecipitate if the fibrinogen is quite low. Prothrombin complex concentrate. This is very important in patients who need warfarin. If they're having anticoagulation, you'll have to go ahead with PCCs as well. And that depends on 25 units or 50 units, depending on per kg, depending on the time and dose and everything. So reversal. So you are addressing the entire hematology thing is a bit complex, but RBCs to maintain stability, because if the more blood loses, the more the patient becomes unstable, difficult to manage an endoscopy in an unstable patient. Try to optimize them as much as possible with all this cover so that they are safe enough to go for. So we are just addressing the leak here. We are not still, the tap is still open. We have to address that. Our job is to fill the pot enough so that the tap can be closed safely. Now, all the serious things aside, what about disposition? So we have talked about dramatic GI bleeds. Do every GI bleed need to get into the hospital? Do everything need to be admitted to the ICU? Do everybody need immediate endoscopy? Not everybody. There is a good chance, if you can see the causes, there is a good amount of them are esophagitis, NSAID usage, Mallory stairs. These people always, you need to correct what exactly is happening, and they can be admitted. The reason it says non-admission with outpatient follow-up on this slide is mainly because the way the system in the UK works is entirely different. But yeah, these are the RCM guidance. Any low risk features are young people less than 60 years, no evidence of hemodynamic disturbances, no significant comorbidities, not currently an inpatient or a transfer from a different hospital, no witnessed hematemesis or a hematochezia, a one-off streaks in the blood needing which after a gastritis episode can probably be managed safely without any issues if it fits into the stable criteria. All right, now we are done with the big thing. Okay, upper GI bleed is done. I'm going to come to the point and talk about second patient now. This is a 66-year-old female who is a retired professor in gynecology, obstetric and gynecology, who has had left-sided abdominal pain, nausea since vomiting. She's taken some over-the-counter medications like paracetamol and other things, did not help her. Has taken some pantoprazole, nothing helped. And in the evening, she had an episode of large volume, fresh PR bleed, which made her come to the emergency department. She says that every time she stands up, she's still feeling faint. That is a bit concerning for me. And that was the bleed. She just took a picture and then came to the AD. What is the next step? Standing, you are concerned about this. Yes, you're going to move to a monitored bed, start resuscitation, put cannulae, get the bloods and everything. These are the vitals. She is tachycardic, hypotensive, again, shock picture. Now, you asked a bit more questions. She is known to have high blood pressure, rheumatic heart disease with stenosis needing a bioprosthetic wall, mitral wall replacement, diverticular disease, atrial fibrillation on apixaban. She has taken apixaban about 8 hours ago. You can probably expect that this pain in the abdomen probably started as a diverticulitis, but now it's complicated, isn't it? She's on apixaban. She needs resuscitation, and resuscitation is not meaningful without reversing the apixaban. You can give 4-factor PCC, about 25 to 50 units per kg. I would involve the blood bank. I would involve the hematologist if available immediately, and then have a chat with this about the transfusion, because they are going to need a lot of resources. And it is lower GI bleed. Upper GI bleed, I've got a lot of drugs, but lower GI, not much. And the other thing, there's a specific antidote for apixaban. It's called andexanet alpha. It's extremely expensive. I've used I've used recently in a patient. It costs about 15,000 pounds for 4 vials. And that is the dose that they need for each patient. It's like 15 lakhs. It's very difficult. You cannot put a price on life. It is expensive. And now let's understand a bit more about GI bleed. So lower GI bleed is anything that is originating distal to the ligament of Treads, small bowel and colon. About 20% of GI all the GI bleeds are lower GI bleeds, and there will be no blood in gastric aspirate. If there is blood in gastric aspirate, that means that the hemodysgesia is actually from the upper GI bleed. The risk factors associated with this poor outcome in these patients is advanced age, hemodynamic disturbances, comorbidities, drugs in patients, just like UGI bleed. The causes, the most common causes in elderly and in general is diverticular disease. It mainly sticks to the Western population. In India, it's anorectal bleeding is a bit more commoner, but in the Western world, this is how it works. Neoplasia, inflammatory bowel disease, which is quite more common when compared to in urban areas when compared to rural areas. And other things might be like other causes you cannot find out. Anorectal disease, about 10%. So 1 in 10 patients, which can be up to 2 in 10 patients in India, is anorectal. So these are the most common anorectal issues like fissures, anorectal fistula, rectal prolapse, perianal abscess, Brodesani, ani. So I am concerned not about these ones. These ones, not much we can do for these in the ED immediately, but this one, portal hypertension, polyps, these are things you cannot compress. So my mental model when it comes to managing the lower GI bleed is it painless or is it painful? Is it associated with pain abdomen or rectal pain? And then go from there. History, just like in the previous, we ask for nature of the bleed, melena. If melena is there, likely upper GI. And if there is, Azim, I'll be done in just 2 minutes. Can I take the questions then? I hope that's okay. So if there is fresh red blood, it is likely to come from the rectum or left colon. And any abdominal pain, weight loss, fever, could be inflammatory bowel disease, probable infections, which is much more common. But what is more common is having, of infections due to bacterial dysentery and everything, malignancies. Importantly, as I said, platelets, NSAIDs, and anticoagulations. Examination, we are going to find amount, the degree of shock, likely source, PR, definitely. Abdominal examination, never complete without a PR. Stool, you can see, you can diagnose some rectal lesions just there. What do we use to classify which is high risk, which is low risk? If there is ongoing bleeding, low systolic blood pressure, elevated PT, confusion, altered mental status, if there is any significant comorbidities, high risk, cannot go home. Non-pharmacological therapy, colonoscopy, strongly recommended by the American Society of Gastroenterology. Initial diagnostic procedure can be also therapeutic as well. So go ahead, colonoscopy should be done within 24 hours if there is any issues. If there is any low risk, if it is high risk, then probably even earlier than that. It can be coupled with, a local adrenal injection, thermal cautery and other things, particularly for AVMs. There is that definitively gives you what the answer is, and then you know what to do. And there's a small chance of perforation by using cautery, but I'm the emergency physician, not a gastro. So yeah. The other things that the gastro can do is hemoclips and band ligations. Angiography might be particularly useful to know. So if the colonoscopy is unsuccessful, then angiography coupled with embolization with an IR, best. But sometimes in lower GI bleed, if the scopy is still normal, you might have to do the scan to see where exactly the bleeder is. And that is which includes technetium labeled scan, which gives you exactly what's going on. And you cannot find what exactly is going on, then you might have to do upper GI scopy as well. And yeah, medical therapy versus surgery is almost very little role of medical therapies in management of lower GI bleed, unless it is a lower GI varices, which we'll have to give terlipressin and other things. But if all of these failed, then you have to open the abdomen. If there is massive bleed and other options have failed, then surgery is the only option. So disposition, particularly the reason I'm talking about this is because if you know what exactly the source is, if it is anorectal source, no evidence of cross-rectal bleeding, it's just streaks of blood when you're going to the poo, they are constipated, and it is probably better to go, probably they're going to be discharged, isn't it? There's no hemodynamic compromise, young people, not on blood thinners. So yeah. And yeah, that concludes my topic. I've referred from RChem, NICE. A lot of photos I've borrowed from internet. I'm not doing this for money, so I think that's okay. Fair use. And Tintinelli and Rosens. Thank you. And I'll take any questions now.
Thank you, Desai. So that was excellent and elaborate and extensive session. Thank you so much. So I know how capable you are, how much capable you are. So you are a pro academician, I could say.
Thanks a lot, sir. Thanks a lot for the word. Seriously. Yeah, it is. The reason this is very important is this. Recently, my friend, unfortunately, I was not involved in this, but my colleague had transfused 12 units of blood in a patient to make them stable enough to be transferred to the endoscopy, to have an endoscopy. 12 units of blood. They have replaced the entire blood volume there. 4 liters approximately.
Nice.
So yeah, it is quite dramatic. Yeah.
Then, if there are any questions, we can take up Desai. Just hold on.
Okay.
So there is a question. So
Yep.
can you please share the dose for injection terlipressin? Can it be repeated? How frequently? Then what about infusion?
So terlipressin, mainly we are going to go ahead. So you can start 2 milligrams to begin with. If it is variceal, I start with 1 milligram. It can be repeated up to so every 4 to 6 hours. I would say every 4 to 6 hours, depending on the body weight. you can start with 1 to 2 milligrams and then repeat up to 4 to 6 hours. It is time buying measure. It is better to address the bleeding. The maximum you can do up to is probably 48 to 72 hours. After that, there is no point. At that time, probably the patient is either too unstable or you have to probably turn east and then say namaste. That's it. 72 hours having GI and then still ongoing bleeding. It's probably going to be end of life sort of a situation there, terminal.
Okay, okay. So Desai, I would like to ask you one thing.
Yes, sir.
So when do you involve medical gastroenterologist if there is a case of upper GI bleed? So are there any specific guidelines? Are there any specific things like that?
Yes, sir. So medical gastroenterology, anybody, the based on the risk stratification, if the Glasgow Blatchford is less than, if it is 1, it is not low risk. Only 0 is low risk. Anybody with score of 1 or more, which includes the hemoglobin, everything, as we can see, anything, they all need to have a gastroenterology review. As you can see on my slide, I don't know if I can see. If they all need to have at least as a non-urgent endoscopy to see what exactly is going on, unless you are very sure that it is just malrevis and everything. Diagnosis is very difficult, particularly in UGI, without a UGI scopy. That gives you answers for most of the things. But I would say with the amount of, to be honest, particularly so things work a bit differently in the UK. In the UK, there is a bit lax culture, risk stratification. It's because of the pot of money. It's the same. So everybody contributes 1 rupee. You have got only 1,000 rupees, which you have to distribute among 1,000 people. So you have to carefully choose which one you are going to do everything. But that is the reason these stratification systems. But with the amount of, it's a bit advanced in India. Actually, we have got much more resources in India, and you've got everything at disposal. You've got much more advanced technology there. So yes, if you're asking the practice, if you're doing in India, I would say everybody needs. They might not need immediately overnight, probably, but at least in the next 24 hours, I think everybody should get medical gas. But if they are having ongoing bleeding, I am going to make sure that the gastroenterologist is going to come to the hospital, even if it is 3 o'clock. I don't care if they have got a 5 tomorrow morning, 7 o'clock, they have got some big thing going on. At 3 o'clock, they have to come to the ICU bedside. If they are risk, if it is a young person or anything, whatever it is.
Yeah. I know about Desai. How you do that?
They have to come. That's it. I refer to you because your role is there. You need to come. You need to take. That's it.
Actually, I will ask one more question. So
Yes, sir.
regarding response time of medical gastroenterologist when there is a need. Example,
Yes, sir.
Friday night or Saturday night. So there is an upper GI bleed. So especially middle of the night. Do they come if you call? Do they come or do they postpone to tomorrow?
If you're talking about the UK,
Yes.
I'm really sorry. This is one of the things. Okay, in the last 5 years that I've been in the UK, this is I would say this is one of the situations where I have not succeeded so far. Basically, the European guidance, which the latest guidance, which has been released literally 3 days ago, says the same thing. There is 3 options. They are too unstable, stabilize and do the GI scopy in the morning time when there is a lot of help, anesthetist and everybody available. 2, there is they are too stable and they can be electively done in the morning. And 3rd is do not call me in the non-working hours. That's most often the situation. But there has been in the recent past, I did admit an alcoholic with, this is about 2 months ago, 1.5 months ago, alcoholic, ongoing bleed in the ED, admitted to ICU, got bedside endoscopy in the ICU about 5 o'clock, about 2 to 3 hours later, after a bit more stabilization. They did too.
Okay.
Yeah.
So there's one more question.
Yes, sir.
CT angio diagnosis.
Yes, CT
Can
angio.
angio diagnose active GI bleed?
Yes, CT angio, particularly if you're going with the arterial phase, can identify the bleeders, but you need to specifically request for this. Not just venous phase, you will have to do arterial phase and venous phase both. then you can do it.
Yes. There is one more question, Desai,
Yes, sir.
by Peter John. So which
Yeah.
criteria cases like this you present can change from medical to surgical in management?
So the most common surgeons are not going to like to open an abdomen where they do not exactly know what the source is. So failure of medical therapy, particularly in, let's say, if it is a bleed, diverticulosis, all right, diverticulitis, particularly diverticular sort of disease, which ongoing bleeding, and you know that there is it is an intraluminal thing. You cannot reach with a colonoscopy. It is too far. And ongoing bleeding, despite medical therapy, you have reversed whatever you can do and then did not settle. Most of the bleeds actually settle down in a good fair amount of time with adequate resuscitation and treatment. But if it doesn't, then surgeons need to get involved and then open the tummy and then either laparoscopic or exploratory open, resect the part out and anastomose it. The chance of them ending up on colostomies and long-term needs is going to be higher.
Yeah, true. So thank you so much, Desai. So we'll wait for 1 or 2 minutes. If no questions, we'll conclude the session.
All right.
So
Yes,
one more
this.
question, Desai. So what about,
Yes, sir.
so if there is a case of malrevis,
Yep.
so how do you involve medical gastro? Or
So
it will be...
malrevis in the UK, if I am very sure that it is malrevis, and there you can see what exactly is going on. So this is a patient who is very likely to be young and then has eaten outside or a recent gastritis bug or something, and then they vomited 2 to 3 times. After that, the 4th time they had seen streaks of blood, and it's not massive. Nowadays, youth are a bit more, particularly after the COVID and everything, people are more health anxious. So knowingly or unknowingly, they are a bit more helpful. They take pictures of the vomit, which are awkward to see, which are I prefer not to see. But yeah, they do take pictures and everything, and you are sure that it is malrevis. Then what we can do is we can just you see you stratify them, and then there is a system in the UK. There is a system called as same day emergency care, same day next day urgent appointments for the scopies. So you can write to the gastroenterology team. They have got elective 2 to 3 slots in a day. Apart from elective, they give emergency, they leave 2 to 3 slots. So we get them back to the hospital next day morning to prevent an admission, because by admitting, we are not going to do much. We've had the bloods. The earliest you are going to repeat the bloods is 12 to 24 hours later. You are not going to give fluids. They are able to tolerate orally. The urea is still normal. They are still okay. Somebody adult responsible lives with them. Send them home. Get them back to the appointment specifically. Ask them to be NBM 6 hours before. They'll come. They'll get the scopy. If it is just malrevis, tata bye-bye. Nothing to do. Bit of PPIs probably. And then correct the cause. If they are still vomiting in the ED, there is a higher chance that there will be progression of the disease. So they should not be vomiting. They should be able to tolerate orally. All of these things satisfied, can send home and then get them back. Even if it was in India, let's say it is 12 o'clock in the middle of the night. Somebody came, had an alcohol, vomited, partying with friends, vomited, had malrevis. We are not going to do a scopy immediately overnight, isn't it? It's going to be next day morning.
Next day morning only.
Yeah, that's
So in certain areas, we need to accept the ground reality. That is
yes,
one of the
sir.
ground realities.
That is it, sir. That is it. See, I say you need to have cordial relationships between this thing. No gastroenterologist is going to be happy to wake him up at 2 o'clock, 3 o'clock for a case who doesn't need. If they are young fellow you have done a medical optimization, there's nothing more. All right, they'll be understanding. All right, this guy did whatever he's done. It's up to me. Yeah. There's one question I can see. Yeah.
How do you decide how many unit of blood transfusion is required?
Clinical. There is no specific number. Clinical. That's it. If you are having a guy who you have given 2 units of blood and then still are having, still are clammy, you are unable to maintain the blood pressure, they need blood. At that point, you might have to think about the other factors as well. Is there, by giving just PRBCs, you are basically diluting the amount of clotting factors as well. If they are needing 4 units, at that point, 4 units is what? 1.2 liters. So 1.2 liters in a blood, and the liver is not going to be able to produce the amount of the natural reconstitution is not going to happen within few hours. So at that point, you have to check. It's clinical. That's it.
Yeah, so well done, Desai. Any other questions? I think no more questions. Thank you, Dr. Desai, for your time, and thanks for sparing your valuable time with us. I know how busy you are. So thanks for
actually miss that
accepting,
days in
thanks
Yashoda.
for accepting our invitation, then being a part of our program. Thank you so much.
The pleasure is mine. Pleasure is mine always.
So
Yeah.
thank you, Dr. Srinath sir, for creating such a great platform to spread our knowledge across all our medical fraternity. And I thank SEMI board, I thank NBI board for your constant support. Then I thank our Yashoda group of hospitals for supporting each and every aspect of conducting this webinar. Then last but not the least, all the viewers of our webinar. I thank Corondal for promoting and for accepting, then standing with us standing with us. Thank you so much. Once again, thank Corondal. So with this, I'm going to conclude the session. Thank you, Dr. Desai.
Have a good day, everybody. Bye.